We're just connecting. Awesome.
Hello.
Oh, great. Munira is here and we have connected. So we want to welcome everybody to our first Instagram live video. My name is Jeanice Mitchell. I'm a pelvic floor physical therapist, and we're so happy to have Munira Hudani, also a physical therapist and a diastasis rehab expert. Munira, please tell us a little bit about yourself and how you got interested in this area of physical therapy.
Sure. First of all, can you hear me okay?
Yes, I can hear you.
Okay, perfect. My name is my name is Munira. I am a pelvic physiotherapist. I have been a physiotherapist for the past 10 years and a pelvic physiotherapist for the past 6 to 7 years. Initially, I started working in more of a general pelvic health practice. I was seeing a lot of men and women of all different conditions. And I set up a practice that was close to a hospital, so there were a lot of good connections with the doctors, the OB-GYNs, and the urologists there. But I realized within a few years that I really wanted to see a lot more or help a lot more women that were prenatal and postnatal. So I ended up finding a place to work that was within a clinic that primarily serves prenatal and postnatal women.
Okay.
And I've been there ever since. So for the past probably 4 years, I've been all women's health, primarily prenatal, postnatal. So I see a lot of women with diastasis.
Okay, good. All right, so let's jump into diastasis. So diastasis, diastasis, they're both correct, right?
Yes, tomato.
Yes.
Diastasis, diastasis. I say diastasis, but both ways are right.
Okay, good deal. So there's a few initials out here that I'd also like to just have you cover. So we have DR, we have DRA, we have DRAM. They're all talking about basically the same thing, right?
They're all the same. Yep.
Okay, so
some are short versions, long versions.
Okay, great. So now please tell us what it is.
Sure. So diastasis rectus abdominis is as it's defined, it's a separation of the rectus abdominis muscles. So diastasis literally means separation, and rectus abdominis refers to the 2 six-pack muscles right on the front of the abdomen, just sort of right through here. And so it occurs during times when there is excessive pressure from inside, and that pressure pushes up on the abdominal wall, and it creates some thinning and stretching of that tissue in between those 2 rectus abdominis muscles.
Okay.
The tissue in the midline, that's called the linea alba. So that's primarily what we're dealing with and working on and focused on when it comes to diastasis rectus abdominis. So it's really that linea alba that gets thinned and stretched, and usually this is what happens in pregnancy. You can't really prevent it. It is something that happens naturally, and you want that to happen as well, because in pregnancy, we need the abdominal wall to provide some of that give.
Yeah, to expand.
As your uterus is growing. So you really do want that give and to create that space. So it is good. It's actually designed to do that. It's designed to thin. It's designed to stretch out. So we don't want to be worried too much about that as it's happening. Just know it's supposed to happen.
Okay.
Yeah, and so I guess traditionally, basically because the name implies diastasis rectus abdominis, it implies there's a separation between those 2 muscles. Our assessment, our treatment, everything about diastasis really has come down to assessing the width of that linea alba, how much space is between the 2 muscles.
Okay.
But, and so we would traditionally do this by assessing with fingers. So we would put our fingers right in the center.
That is what I learned in the 90s.
Yeah, exactly. So we put them right in the center and see how many fingers can fit between the muscles, and we would have a measurement to go off of. It could be 2 fingers, 3 fingers, 2 hands width, but we're now seeing a shift in our understanding. So as our understanding and evolution of diastasis grows and evolves over time, it's become less about how many fingers you can fit inside, and it's becoming more about what is the quality of the tissue that's there,
Mm-hmm.
the quality of the connective tissue. Is there still good integrity? How much and how far can you press your fingers through? Can they sink all the way through? Just the overall appearance of the abdomen, how distended the abdomen is as well. So it's not just about how many fingers, it's really about the quality of the connective tissue
and the tension
that was stretched and how much of that has still remained in that stretched lax position.
Good. Let me jump in here. Hello to everybody joining us. We're so happy to see
everybody.
Our friends and people. We got a lot of questions, and so we've decided to have a 3-part series, and so we're going to get to some of the questions today, but we won't be able to address all of the questions. So just know, if we don't answer it today, we're going to be meeting again in 2 weeks from today, and then also again in January. So please send the questions, and we have them split out to what we're going to be covering today, and then also in the upcoming series. Okay, so now let's go ahead and talk a little bit about how does the pelvic floor tie into diastasis.
Right, okay, so when it comes to treating diastasis, you might think about treating the rectus abdominis muscles, because that's what, again, the name of the condition is diastasis rectus abdominis. So you're thinking about how do we get these two muscles to come back together. So, but in actuality, what we're trying to do is work on the inner core muscles and not on the outer core muscles. So we're actually needing to work on that inner system that contains the organs, that holds the organs in, that holds and contains intra-abdominal pressure. So it's a system that actually doesn't really involve the rectus abdominis, and it's the system that really does get stretched in pregnancy, and as a result of that, the rectus abdominis sort of moves apart. So we're working on that inner system instead. So the 3 muscles, well, actually there's 4, but the 4 muscles that are involved in this inner core are the pelvic floor, the transverse abdominis, the diaphragm, and the multifidus. So they actually form like a bit of a canister inside of our abdomen. And the diaphragm is the top, the pelvic floor is the bottom, all around it is the transverse abdominis, and there are some tiny muscles in the back that we're including right now as part of that core. So that transverse abdominis muscle, it's the one that's responsible, like I said, for containing pressure and managing the organs, keeping them inside of you. And when that's not doing a good job, you're going to see doming and coning. You're going to see that pressure push through the linea alba. So that is almost a weakness of the transverse abdominis muscle. So how does that relate to the pelvic floor? Well, you can see they all kind of are part of the same system. You really can't work the transverse abdominis without working the pelvic floor, and you can't do either of those without addressing the diaphragm, and some would also say the multifidus as well.
Right.
So that's how the pelvic floor actually is related to diastasis, even though it seems to be pretty far away.
Good, good. Thank you so much. Okay, so let's go ahead and jump into some questions, all right? So number 1 would be, how long does it typically take to heal?
Okay. Now, it seems like a very simple question, but it's not, because honestly, everybody starts with a different place. Everybody has a different starting point. And so it depends on how much connective tissue laxity, how stretched the tissues are, and how much of that is remaining afterwards. It depends on how strong or weak your muscles are, what you're starting with. It depends on how easily you can connect to your muscles. And all of these will determine how fast you will go through the rehab and the strengthening process. So it's not a very clear-cut answer like that, but what I can say, it depends. But it depends on if, let's say it's primarily a muscle weakness. Well, muscles, as you go to let's say you're going to the gym, it takes a few months before you start seeing really significant changes. So from a muscle perspective, it could be several months. But if there's a lot of connective tissue laxity in the system, in addition to muscle weakness, then it'll be significantly longer, just because collagen turnover is much slower than muscle turnover. So muscles can get stronger and better faster, collagen takes time, and that could be 6 months to 2 years. So it could be, I guess my short answer, but very vague, would be from about 3 months to about 2 years.
Okay, great. Thank you. Now, another question, how do I know if I have it or not? How do I check?
Yeah, that's a really good question, because you do want to know if you have something going on that needs to be addressed. So one of the telltale signs that you can sort of be aware of is if you see that doming or bulging or coning, and I feel like they're all pretty much synonymous words, just to show that there's pressure that pushes through the linea alba. You will see this if you're trying to, let's say you're lying on your back and you're trying to sit yourself up, you'll see that's one of the places where you'll see the doming. You could also just sort of lean back and try to lie down that way, and you might see it there. So that's one way to know if you have it. Another way is just simply by assessing with your fingers, using that finger method. So what you would do is you would lie down on your back. You would so you would just actually try to locate the space between the two rectus abdominis muscles. So just maybe stand up here. So knowing that the muscles, let's say right now, are here, you're trying to see how many fingers fit in between that space. So you would just see if you can locate the borders of the muscle, find out how many fingers you can fit in between. If you can figure that out without lifting your head, then you have your answer right there on how many fingers or how wide it is. But let's say you're having a hard time finding the borders of the muscles so that you can really know what's in between them. Then you want to lift your head up. It activates the rectus abdominis, and in that activation they pop up a little bit more to make it more distinguishable what's happening inside of that. So you really don't want to lift your head up too high. You're trying to get your measurement from as close to resting as possible.
Okay.
It's just a little bit of a head lift.
A little bit.
But again, sometimes you just can't feel the muscles, so you have to lift a little bit further to get them to engage a bit more. Then you'll feel much more.
Okay, great. Welcome everybody that is joining us. We're talking about diastasis recti. We're having some great questions, and we have a lot of questions that we received coming into this interview. So we're going to answer as many as we can today, and those that we don't get to, we're going to cover either at our session in 2 weeks or in January. So our next question is, if the gap is 1 finger or less, but there is still coning or pressure, is this diastasis recti, or is it functional separation? And then if it's functional, what does functional mean? That's kind of like 5 questions.
Yeah, so the question as to whether a diastasis is functional or not comes down to the ability of your muscles, namely your transverse abdominis, to put tension through the linea alba. So we're trying to make it so that there's no doming and pushing through that area. So if your transverse abdominis can contract, and it contracts this way, then it creates tension in that system, which makes it much harder for pressure to push through. So it contains it well. So if you have that happening, whether you're doing it actively, you're telling your body, okay, turn on TA, and then you do your plank, and you don't see any doming, then that's functional.
Okay.
If you're trying to turn it on and you still see doming, then it's not functional in that exercise. So that's important, because you want to know that you may not be functional in some positions, some movements,
it might be too hard.
Exercises. In some you are, exactly. It doesn't mean you're not functional, like all across the board.
Yeah, that you're just awful, right? You could be, different activities are harder for different muscles to turn on.
Exactly. And positions, and how you're doing your exercise plays a role, and really how strong you are at that point will play a role as well. But let's say you find that you're doming, and you find that it's just not functional at that point in that exercise that you're doing. You want to see if you can find an easier version of that exercise where you're not doming, and work at that, and then work up to and progress over time to the harder version.
Good. Excellent. Okay, so now going on to treatment options. So what core exercises can I do? So this is a huge question. What can I do?
Yeah.
At 3 months postpartum, I was diagnosed with a 1 to 2.5 finger gap. Now she's 10 months postpartum. So
Right.
what is safe?
Okay, it is a big question. So this one will take a little bit of time. But okay, if you're 3 months postpartum, whether you're 3 months postpartum or let's say 2 years postpartum, I would say it has less to do with how far along postpartum you are. It's more about what are you starting with? You know, what is your starting point again? So we'll use that more or less as our idea of what to start with in terms of exercise. But just generally speaking, because I have no idea, I haven't seen this person, and I don't know what her core looks like, but just generally speaking, I would first work with you to see if you can connect to your inner core muscles. In order to strengthen them, you really need to be able to tell them what to do and know where they are and know how they're supposed to contract. So I would get you to find and connect with the muscles first. Now, namely, again, these would be the pelvic floor, the transverse abdominis, and the multifidus.
Are the muscles doing the right
and the
thing?
pelvic floor.
Like the muscles doing the right thing at the right time?
Exactly. So we can go over very briefly, and maybe just 3 of them right now. So how to connect with your pelvic floor, how to connect with your TA, and how to connect with your diaphragm.
Good.
Okay, so maybe we'll start with the diaphragm.
Good, that sounds good.
Like I said, this is a big question.
3 pieces of homework here.
Exactly. Okay, so the diaphragm. Now, the diaphragm, that's our breathing muscle. Remember, that's the top of our canister, and it works with the pelvic floor. They kind of just do this up and down motion all day long. We want to work the inhale, and we want to work the exhale. So the inhale, what you're trying to do. What
is safe?
Okay, it is a big question. So this one will take a little bit of time. But okay, if you're 3 months postpartum, whether you're 3 months postpartum or let's say 2 years postpartum, I would say it has less to do with how far along postpartum you are. It's more about what are you starting with? You know, what is your starting point again? So we'll use that more or less as our idea of what to start with in terms of exercise. But just generally speaking, because I have no idea, I haven't seen this person, and I don't know what her core looks like, but just generally speaking, I would first work with you to see if you can connect to your inner core muscles. In order to strengthen them, you really need to be able to tell them what to do and know where they are and know how they're supposed to contract. So I would get you to find and connect with the muscles first. Now, namely, again, these would be the pelvic floor, the transverse abdominis, and the multifidus.
Are the muscles doing the right
and the
thing?
pelvic floor.
Like the muscles doing the right thing at the right time?
Exactly. So we can go over very briefly, and maybe just 3 of them right now. So how to connect with your pelvic floor, how to connect with your TA, and how to connect with your diaphragm.
Good.
Okay, so maybe we'll start with the diaphragm.
Good, that sounds good.
Like I said, this is a big question.
3 pieces of homework here.
Exactly. Okay, so the diaphragm. Now, the diaphragm, that's our breathing muscle. Remember, that's the top of our canister, and it works with the pelvic floor. They kind of just do this up and down motion all day long. We want to work the inhale, and we want to work the exhale. So the inhale, what you're trying to do to connect to your diaphragm and breathe diaphragmatically is you want to take an inhale and breathe down, and you want your ribs to open up. So
let's try that.
Right over here, right where the bra would be across your entire body.
Okay.
You want to expand into the entire circumference of that rib cage. So not just sideways, but you want to breathe into the front and the back.
The whole rib cage expanding.
360 degrees around, exactly.
So we're taking a deep breath in and trying to expand the whole rib cage.
The whole rib cage, exactly. So you want that breath and to encourage it to come down into you rather than be held way up here into your neck and shoulders. So my cue is usually to breathe down.
Okay.
Fill yourself up with the air. So the breath has to be balanced between the rib cage and the abdominal wall. So you do want some abdominal wall expansion as well as some rib cage expansion.
That's a helpful
at the same time.
And any position, or should we start in a specific position for that?
You would start in any position that you can do this well in, and usually lying down. and then work towards standing, because that is functional. I want to get everybody able to do everything, that all the exercises in standing.
Yes. Sometimes it's easier to learn them lying down because all the other muscles are kind of turned off and they're quiet. But it's not functional lying down, because we live and we walk and we work and we lift, and we need the muscles to be engaged with what we're doing.
Exactly.
Excellent.
Yeah.
Okay.
Yeah. So the inhale is breathing into the rib cage and abdomen, balanced between both, not just belly breathing and not just rib cage breathing.
Okay.
The exhale is where you're trying to just passively let everything fall back down. It's tension free. You're not trying to force the breath. It's an easy passive exhale.
Okay.
So that's diaphragm, the inhale and the exhale.
So that's homework number one.
Diaphragm through your breath.
Good. So everybody got that. Homework number one is diaphragm, starting lying down and then progressing to functional positions and activities, and practice doing it when you're upright with activity. Yeah, exactly. Okay, and then the next we can do is transverse abdominis. So the TA muscle, as I talked about before, it wraps around the abdomen. It sort of goes circumferentially around the abdomen, and the way it contracts is it pulls inwards, and it sort of reduces the size of the abdominal canister. So you want to encourage that drawing in action, and you want to see if you can do that. So some of the cues that you can use to connect to your TA are, and maybe you want to do this in a seated position or standing, you want to see if you're able to just draw your belly button inwards towards your spine. Okay.
You want to do it in a controlled way, not forcefully. You're not using other muscles to do it, but you literally just want to see if you can just draw it inwards towards you, kind of to create a flattened abdomen.
Kind of like if you were trying to zip up a tight pair of jeans.
Yes, that's a cue that you can use. Yeah. So zipping up your pants so that you're not sort of pulling in so you don't pinch yourself. If you have like tight pants.
You guys aren't playing with different things here.
I don't know how to filter on it.
This is awful. I'm just going to go to this one. Oh boy, okay, good. That went away. I'm so sorry, everybody. That looks really unprofessional. But we're learning.
That was awesome.
We're learning with Instagram Live, and I'm pressing buttons that I didn't know what did. So I'm sorry to interrupt you. Okay, so we're back to the transverse abdominis and activating it.
Okay, so for the transverse abdominis, to activate it, I actually find lying down is the hardest for people to feel it. So I usually get them to do it in sitting or in standing. And like I said, anything that encourages drawing in of the abdominal wall is a good cue for you. And that could be just pull your belly button towards your spine, or pretend that your belly button is even lower down to where your underwear is and try to pull that towards your spine.
Okay.
Or pretend it's a little bit higher and pull that towards your spine. Because the transverse abdominis, it's from top to bottom. It goes around the entire...
And from the rib cage all the way down to your pelvis, basically.
Yeah, so you want to know all the areas. You want to control all of them.
Is there something that we should avoid specifically with transverse abdominis contractions?
Well, the common compensation patterns would be things like using your upper abdominals only, like right in here. These muscles tend to do a lot of cinching, and they tend to take over. So I would definitely avoid using your upper abdominals to do it, and or sort of like sucking in, like you're just sort of lifting everything up. That's a little bit different as well. You're trying to actively draw inwards.
Okay, good. And thinking about the lower area. Okay.
Especially that area, it becomes more weak in pregnancy. So
hello everyone that's joining. So we're covering questions that we have gotten over the last several days, and if we don't get to the questions today, we have a part 2 coming up in 2 weeks on the 19th, and then also a part 3 coming up in January. So we're so happy to have you join us. 3 ways. So we have diaphragm as our first exercise, transverse abdominis is our second exercise, and our third one is
pelvic floor. The pelvic floor, my pelvic floor muscles.
Yes.
Okay, so to to activate or to connect to your pelvic floor muscles. So what I typically do is I first of all do a lot of education, but what I would recommend is just, again, sitting on a chair. And if you can just sort of lean yourself side to side and just feel the two sits bones that are there under the bum that you're sitting on, in between, that's where your pelvic floor is. So just simply knowing where they are can help you locate them and contract and connect to them. So from there, I would talk about the three different cues, the three different areas, the front and the middle and the back, because the pelvic floor, it controls where the urethra is, it controls the vaginal opening, and it controls the anal sphincter. So just connecting to these different parts. Most women have no idea that there are so many little variations in the contraction that you can do. So there's more to a Kegel than you think. So some of the cues that you can use for connecting to the pelvic floor are stopping the flow of urine. That would be for the front, where the urethra is. For the middle, where the vaginal opening is. Contracting as though you are drawing around a marble and pulling it in. And especially the drawing around and closing the vaginal opening and then pulling it in.
Up and in.
That's in and up, exactly. That's a really good cue. And then for the back, trying to stop gas from escaping.
Exactly, that is
you can
a
try
favorite one.
Is that your favorite? Yeah, or you could try like a marble, pulling a marble into the anus, and that can work as well. So just spending a few minutes with that. So that's your connection.
That's good. Just one word of caution about the stopping the flow of urine. So we're talking about doing this when you're sitting, not on the toilet. So we don't want to do that on a regular basis on the toilet.
Exactly. Yeah, not on the toilet. You're not doing Kegels when you're actually peeing on the toilet. You're doing them separately as part of an exercise program. Not on
this is a visual cue for you to understand which set of pelvic floor muscles to contract. So that's good. So we have 1, 2, and 3. There was a question here about how often do we need to activate the transverse abdominis for it to help. So
okay. Well, if you're just building that connection, it's less about how many repetitions you do and like do 30 repetitions 3 times a day. We'll talk about more about that like when it comes to strengthening. But when you're just trying to find the muscle and connect to it, it's more about taking time to do it. I usually recommend 5 to 10 minutes every day, working on breathing, transverse abdominis, and pelvic floor. And then from there, connecting them all together, coordinating them so that the diaphragm and the pelvic floor work together.
Good. Okay, so we're moving on to, should I breathe while holding in my pelvic floor and doing Kegels or DRA exercises? So it's very similar to a question that we just got there. Or should you only contract and release? So where does breathing fall in?
Yeah, so I think when it comes to that question, should you be breathing while holding or should you just be contracting and releasing? I think it depends on what you're working on. So it's totally fine and legitimate to just be contracting, practicing contracting and letting go of your pelvic floor. That on its own might be enough and mentally challenging enough for a lot of people. So if that's what you're working on, great. And then as soon as you get that, you want to be able to contract a bit further, go a bit more. Now you're going to encourage more strengthening of the muscle now that you know how to contract and let go of it. But at the same time, you could also work on building endurance. That's where you're holding the muscles longer, 10 seconds, 20 seconds. So you can do both. You can do contract and relax, and you can do longer holds. And for sure, when you're doing your longer holds, you want to be breathing.
Okay, good. If you have any other questions, audience, on breathing in the pelvic floor, send it our way, please. We're going to move on because we have a few more questions that we want to cover today. My diastasis recti is up high, like there's a baby bump right under my boobs. What exercises should I be doing to repair it? Also, I've had diastasis recti for 5 years. It occurred when I was pregnant with my second child and was exacerbated with my third pregnancy, which was a large baby.
Yeah. So just like we were talking about earlier, the transverse abdominis, it covers the upper, the middle, and the lower abdomen, and it goes around the entire midsection. So different parts of this muscle and the entire abdominal wall can be stretched in different ways, and each person will have their own unique presentation. I would say the majority of women will have most stretching happening near the level of the belly button, so that will be the widest part of stretching, but in many cases it's higher, many cases it's lower, so everybody is different. So in your case, it seems like more of the stretching happened above, or it may have happened before, like below that as well, but that had all sort of naturally pulled in, and now what you're left with is more of a baby bump near the top. So if that's the case, you want to really try to find your transverse abdominis and connect to it up there. So you want to continue working at the lower, the middle, but definitely encourage that pulling in up near the top and really try to connect up there instead. So you could even use your fingertips and place them right where that weakness in the soft tissue is. And when you're trying to contract, like the cue that I said, is pretend your belly button is a bit higher, and see if you can draw that inward until you feel the linea alba is actually a bit firm now rather than soft. And you just keep doing that over and over, and probably in different positions too. So whichever position allows you to achieve that, try sitting first, try standing. That's the position to work at.
Okay, good.
Once you can do that there, then you would want to continue doing that inside of all of your other exercises. Let's say you want to do planks, you want to keep your focus up at the top so that you are always encouraging the body to kind of go there and strengthen and keep those muscles on at the top.
Yeah, good, engage, right? Because it's a muscle that's stabilizing, so we need it to be active in everything that we're doing. But training it in easier positions, easier activities, and then advancing.
Yes.
Good. Okay, so now, does binding after pregnancy prevent diastasis recti?
Right, okay, so binding and splinting, they're all things that I get asked a lot about. Is it useful to splint afterwards? So diastasis occurs in the pregnancy. It's not something that usually occurs afterwards. The most stretching that will happen in the pregnancy. So when you're talking about postpartum, what you're trying to do with a splint or an abdominal wrap or a binder is to help encourage everything to sort of come back in and for the abdominal circumference to just sort of become narrow again. And so to encourage things to just sort of drop inwards again. And so it's not something that you can use to prevent diastasis because, like I said, it's kind of natural and you need some of that thinning and stretching to occur in pregnancy. The postpartum, a lot of women do feel they have no muscles. Like immediately postpartum,
it's like
feel
mush,
like hollow,
like you're just mush.
mushy.
Yeah.
Is it useful to splint afterwards? So diastasis occurs in the pregnancy. It's not something that usually occurs afterwards. The most stretching that will happen in the pregnancy. So when you're talking about postpartum, what you're trying to do with the splint or an abdominal wrap or a binder is to help encourage everything to sort of come back in and for the abdominal circumference to just sort of become narrow again. And so to encourage things to just sort of drop inwards again. And so it's not something that you can use to prevent diastasis because, like I said, it's kind of natural and you need some of that thinning and stretching to occur in pregnancy. The postpartum, a lot of women do feel they have no muscles. Like immediately postpartum,
it's like
feel
mush,
like hollow,
like you're just mush.
mushy.
Yeah.
Exactly. So you feel mushy, hollow, vulnerable in the back, like vulnerable to injury when you're lifting your child. So the abdominal binder can really support the muscles postpartum by providing them with a little bit of compression and just gives the body the support in the place that it really needs it, knowing that those muscles aren't really working that well immediately postpartum.
Good.
So it is something that I do recommend. I usually recommend women to wear them for the first 6 to 8 weeks postpartum. Again, just to give the muscles
support.
a little bit more support. But in conjunction with exercise, some sort of exercise, core exercise
It can't
program.
replace
so not just
it.
by wearing the abdominal binder by itself, but you have to do it in conjunction with an exercise program. Otherwise, yes, your body might just get dependent on it. and you might develop some atrophy of your muscles as well. So,
like they don't need to work
rehab
anymore. They have this external support, so why should you even try to engage? So binders are good up to 6 to 8 weeks to give some extra support, but then we want to wean off, and also from the beginning we're working on engaging that deep core, right?
From the beginning, like within 24 hours after delivery. And if you have a lot more stretching of the connective tissue that's lingering, you might want to wear it longer. So it's not a hard and fast cutoff at 6 to 8 weeks, but if you're not able to connect to your muscles, you can't turn them on actively before you want to lift your child or lift the car seat. If you have a hard time doing that and things are really stretched out, you might still want to wear it longer.
Okay. One question that kind of goes along with this that we just got in was, how long at a time do you recommend binding, and would you wear it while exercising?
Great question. Okay, so I would recommend wearing it as soon as you deliver, like within 24 hours, you can wear your abdominal binder. It should not be so tight that you can't breathe. It should be a light compression.
It's not pushing down either.
No pushing down, exactly, because that's what can happen. It can push down on your organs and create some other problems like prolapse.
Yeah.
So we really are trying to avoid that.
And weaken that pelvic floor underneath.
Yeah, exactly. So within 24 hours, and then I would say wear it 24/7.
Okay.
So as long as you can tolerate it. Let's say you get hot and sweaty, it's itchy, take it off, give yourself a break, and then put it back on when you can tolerate it again. And just wear it as much as you're able, including when you're sleeping. And would you wear it during exercise? Well, not when you're initially starting to connect to your muscles. You need everything just to be available to you so you can see how much you can activate your muscles and draw in the abdominal wall actively. If the support binder is there, it's already pulled everything in for you.
So you're not having to use your muscles to do it.
That's right. You don't have to use your muscles. Yeah. So you want the full in and out. You want to be able to feel that. So not during the exercises.
And then we're gradually, so we're wearing it 24/7 initially, and then we're gradually weaning off. Do you have a timeline that you would say that you want people to weaning off, so that by 6 to 8 weeks they're binder free or close to it?
Yeah. So, and I think it's case by case.
It's dependent.
But it's very dependent, because a lot of women are going to be fine. At 6 to 8 weeks, they have already connected to their pelvic floor, their TA, their diaphragm. They know how to activate and coordinate things. They can use them, and then we just need to strengthen them. But if you're having a hard time connecting, and you're still very stretched out, then I would still say you want to continue wearing it.
Okay. Yeah, because you're
Until
vulnerable.
You can do that.
You're vulnerable to injury. And then think about, as a new mom, you have your whole core is stretched out, your pelvic floor is stretched out, whether you had a vaginal delivery or C-section, and then you're doing all these things. You're lifting a baby, you're lifting the car seat, you have a diaper bag, you're, a stroller. I mean, there's so much involved in being a new mom, and you think about all of these things that are putting pressure on the muscles. So we really want to support and protect and keep them safe. Activate those muscles while you're doing it. So remember our 3 exercises. We have the diaphragm, the transverse abdominis, and the pelvic floor working together, and you gave some great tips there. Okay, now, will splints help with diastasis recti? I find this helps with stomach muscle pain. So I think, yeah.
Right. Yeah, I actually think it's such a good point, because we're often, when I first started learning about diastasis, we were taught that diastasis is not a painful condition, that you shouldn't feel any pain at all. But in clinical practice, I have found that so many people are coming in actually saying they feel a bit sore. To me, that makes sense, that there can be some soreness, especially if the muscles are weak, and they're trying to turn on in some of the heavier tasks that they're doing. And because that's what can happen. It can push down on your organs. And create some other problems like prolapse.
Yeah.
So we really are trying to avoid that.
And weaken that pelvic floor underneath.
Yeah, exactly. So within 24 hours, and then I would say wear it 24/7.
Okay.
So as long as you can tolerate it. Let's say you get hot and sweaty, it's itchy, take it off, give yourself a break, and then put it back on when you can tolerate it again. and just wear it as much as you're able, including when you're sleeping. And would you wear it during exercise? Well, not when you're initially starting to connect to your muscles. You need everything just to be available to you so you can see how much you can activate your muscles and draw in the abdominal wall actively. If the support binder is there, it's already pulled everything in for you.
So you're not having to use your muscles to do it.
That's right, you don't have to use your muscles. Yeah, so you want the full in and out. You want to be able to feel that, so not during the exercises.
And then we're gradually, so we're wearing it 24/7 initially, and then we're gradually weaning off. Do you have a timeline that you would say that you want people to weaning off, so that by 6 to 8 weeks they're binder free or close to it?
Yeah. So, and I think it's case by case.
It's dependent.
But it's very dependent, because a lot of women are going to be fine. At 6 to 8 weeks, they have already connected to their pelvic floor, their TA, their diaphragm. They know how to activate and coordinate things. They can use them, and then we just need to strengthen them. But if you're having a hard time connecting, and you're still very stretched out, then I would still say you want to continue wearing it.
Yeah, because you're vulnerable.
You can do that.
You're vulnerable to injury. And then think about, as a new mom, you have your whole core is stretched out, your pelvic floor is stretched out, whether you had a vaginal delivery or C-section, and then you're doing all these things. You're lifting the baby, you're lifting the car seat, you have a diaper bag, you're, a stroller. I mean, there's so much involved in being a new mom, and you think about all of these things that are putting pressure on the muscles. So we really want to support and protect and keep them safe. Activate those muscles while you're doing it. So remember our 3 exercises. We have the diaphragm, the transverse abdominis, and the pelvic floor working together, and you gave some great tips there. Okay, now, will splints help with diastasis recti? I find this helps with stomach muscle pain. So I think, yeah.
Right. Yeah, I actually think it's such a good point, because we're often, when I first started learning about diastasis, we were taught that diastasis is not a painful condition, that you shouldn't feel any pain at all. But in clinical practice, I have found that so many people are coming in actually saying they feel a bit sore. To me, that makes sense, that there can be some soreness, especially if the muscles are weak, and they're trying to turn on in some of the heavier tasks that they're doing, and they can get strained in that time. That's that vulnerability piece that we're talking about. So, of course, in these cases, that binder or that support can really help, just to give those muscles a little bit of cushion to support and to sort of work with, and to provide that relief.
Good. Welcome to everybody that's still joining us. Real quick, to answer this question about cueing the pelvic floor. So about a few minutes ago, we covered some great tips for that. Basically, you're thinking about squeezing, or like if you had to urinate and you're trying to stop the flow of urine, or you have gas and you're trying to hold that gas in, or I like the one that you said with the vaginal canal, if you had a marble and you're trying to pull up and in. These are done not on the toilet, so we're not doing pelvic floor muscle activation on the toilet. Okay, so now we're moving on to hernias. So this is a big topic. We got several questions on this, and then this is going to be our last category for today, and then we're going to cover some of the other questions that we're getting at our next session in 2 weeks. So the next one is, what is an umbilical hernia, and would a belly button ever go back to how it was pre-pregnancy?
Such a good question. Yeah, so with diastasis and pregnancy, it's one of those things that you don't really talk about a lot either, amongst the likes of constipation and hemorrhoids and painful sex. Even belly button changes, that is not really talked about either. So typically, in any belly button that is pushed out in pregnancy, typically it does go back in and resolve over time. But depending on how much stretching and how much thinning, how much pressure was underneath the belly button at that time, after delivery, you can still have a belly button that's in but looks different. It could look wider, it could look more shallow, it could look larger as well, so it can look different. Now, if you're noticing a lump or a bulge inside of the belly button, if you're noticing something is there that wasn't there before, then you might want to check to see with your doctor if there is an umbilical hernia, because that's typically what you'll see, and not in all cases, but sometimes you'll see a little bit of just a lump or a bulge that's there. Most cases it's not tender, it's not painful, there's just something there that it could be fat or intestine, or it could be fluid that's just pushing through. And if you can reduce it just by sort of pushing your finger through, and if that can go in just naturally without pain, often it's not a problem. But it's when you can't do that, or when it becomes more painful, it becomes sore, red, these are signs that it's irritated, and it could mean that there's something that's actually getting stuck or called strangulated in that area, and it's a medical emergency, so you want to go to the doctor right away. But if it's not painful and that there's just something there that looks different, you might still want to go to your doctor to see if it is in fact an umbilical hernia.
Okay, good. And then what is the connection between an umbilical hernia and a diastasis?
Right, okay, so there is a connection because they both happen from the stretching and the thinning of the connective tissue and the weakened muscles. So they both occur from that reason. There is a connection as well because if you have a little hernia, a small hernia, and you have diastasis happening at the same time, and you're doing exercises that really load that tissue from the inside, so high intra-abdominal pressure exercises, ones like planks and sit-ups. If you're loading through it, the diastasis implies there's a weakened connective tissue there, including where the hernia is, so it could in fact make the hernia worse. So it's not to say that diastasis always causes hernia, but there's a correlation because diastasis is thinning of the tissue, so it's more vulnerable if there's a small little tear there, that it could become more pronounced if you're loading it beyond what it's capable of.
Mm-hmm. Okay, good. And then the last question here under hernias is well, I think we just covered this. What is the connection between diastasis and hernia, also regards to possibilities to heal or improve?
Right. So the healing of a hernia, it is an actual hole in the tissue. There's a tear that's there, that something is now pushing through it. So that really can only be corrected if it was done through surgical correction, whereas diastasis can heal, and you can encourage connective tissue drawing in and thickening, and by loading it and progressively strengthening the muscles around it over time. So one usually is more surgical, and one is more, it can be done conservatively, depending on the state of diastasis as well.
Okay, great. Let's see. Do you have any tips on exercises for the multifidus? So the multifidus is a core muscle, or at least some people, categorize it with the core. Any tips on that?
That is a hard one. Multifidus is a hard one for most people to find, and I can try to explain it to you, but for me, like if I can feel it, I can tell you if you're doing it right or wrong.
Something that I liked that we just covered at a class that I was at. So if you take your hand and you put it on your low back, okay, and then kind of arch your back like you're sticking your bottom out behind you, and you'll feel those muscles kind of bulge under you, okay? That's not multifidus, so that's not what you're after. It's those deeper muscles. So with one hand, again, keep it on your low back, but then if you have a table or something solid in front of you, take your other arm and gently push up on that table. And you should feel some deeper tension there, not those bulky muscles that are popping out at you, but some deeper tension, and that's more likely to be your multifidus. But the thing is, we can't just say, yes, your multifidus is turning on without putting our hands on you. So these are some tips and some things that might be able to help you, but we can't know for sure without hands-on. But the biggest thing is multifidus. If you feel a big bulging muscle, that's not multifidus. It's a smaller, deep core muscle. Okay, and
I often find, I was just going to say that I often find if you're doing your transverse abdominis contraction, if you put your hands on this, like right along your spinal column, where you feel the little bony prominences just beside it, you will feel that tensioning in that region. So it'll help you just to connect to that area.
Visualize it. Okay, good, very good. Okay, so we have more questions coming in, but we are going to have to take some of these questions and cover them. We're going to be back in 2 weeks. December 19 at 10 a.m. again. We'll cover, I saw low pressure fitness coming in here. We'll cover that. We're also going to cover some of the bloating and more questions. So keep sending the questions. We're going to prepare a list and try to cover as much as we can. And then we're also going to have another session in January. So thank you guys so much for joining us. We really appreciate you spending your time with us this morning. And I want to say a special thank you, Munira, for all of your time preparing this and your expertise and being willing to share it with us. We really appreciate you.
Thank you so much. I'm so glad to be here.
Thank you.